Hello and good morning, everybody. So today we are gonna again continue with our series of questions to answer some of the MRCP questions to prepare for the exam. For those who have just joined us, I'm gonna tell you that I'm using Anki to go through various sets of questions from the PasTest question bank or the PassMedicine question bank, um, and sometimes from also the own examination. So in this series, I'm selecting various random questions using Anki software, and we'll go through the questions together. Most of the questions I don't know the answer for them, so I'm gonna answer them with you as we go through. Okay, so let's start without further ado. I'm trying to make those series about 10 to 20 minutes, so let's go through quickly the first question. The first question is 28-year-old woman. She is 14-week pregnant, and this is her first pregnancy, okay? And she attends for routine antenatal check. Her only past history of note includes 2 admissions to the hospital with pyelonephritis as a child. She takes no regular medication. She is healthy otherwise. So her blood pressure, we notice that is a little bit high, and it is rechecked an hour later, found to be again high. So there is 2 sets of blood pressure measurements. There is no other significant abnormality. Sodium is fine, potassium is fine, urea is fine. Her creatinine level as well is a little bit high. Urine analysis are remarkable. Ultrasound scan is showing that the right kidney of normal size, but the left kidney has a smaller size, so this could be because of the pyelonephritis as a child, leading to scarring of the kidney. So the left kidney is also showing a regular outline. So what is the likely diagnosis? Is it scarring due to recurrent pyelonephritis? I think so, but we'll see. Is it genital renal atrophy? Is it glomerulonephritis? Okay, if it is glomerulonephritis, you would expect some blood or protein in the analysis. In this question, your analysis was normal. Is it preeclampsia? Now, preeclampsia, you would also expect to find some protein, isn't it? And the renal artery stenosis. Now, renal artery stenosis is possible because that's causing, that could cause different sizes in the kidney. I'm gonna go for answer A, and indeed answer A is the correct question. Let's go through the explanation quickly. So this woman has a hypertension in pregnancy, of which there are many causes, okay? So there are many causes for hypertension in pregnancy, among them also the preeclampsia, isn't it? Now, what is the ultrasound scan shows? It has shown a damaged left kidney, and this is suggestive of renal scarring that has been recurrent through her childhood. Okay, chronic long-term renal damage related to pyelonephritis may predispose to the development of hypertension. So the scarring, okay, so that explains then why she had some hypertension, is because of the scarring. And then you can use enalapril, bendrofluothiazide, hydralazine, atenolol. These are not recommended for treatment of hypertension at this stage of pregnancy, okay, because some of them are teratogenic. But so what is the one would be recommended? It is the methyl-dopa would be an acceptable choice. Okay, so methyl-dopa always can be used in pregnant women. Okay, long-term management of this condition involves, So what is the long-term option? Is the identification of predisposing risk factors such as abnormal ureteric implantation. Okay, so if there is a problem in the ureter or other structural problem that might be suitable for surgical repair. Okay, so you go for the predisposing factor that could be corrected surgically. Okay, so how many answered correctly? About 60% answered correctly, and about 15% answered B or C, which is congenital or C glomerulonephritis, and we understand why it cannot be like this. Okay, anything in the overview? These are some of the explanations of this question. Okay, some presentations here for the UTI, such as dysuria, frequency, urgency, nocturia, suprapubic pain, nausea, vomiting, acute confusion instead. Okay, that's fine. Clinical signs will be the tenderness and the odorous urine, the cloudy urine, hematuria, rigors. Differential diagnosis, pyelonephritis, urolithiasis, which is stones in the ureter, interstitial cystitis, okay, STI, okay, that's fine. Management, non-pharmacological, okay, I don't think we need to go through all this explanation as long as we understand what's happening here. Okay, so in this question it's more of a renal question now. Okay, so how did we answer this question? I think we answered it properly. So what is the next question we can go through? Okay, it seems that this is one of the questions that I've answered earlier. Let me see if I can remember. It's 24-year-old lady, 3-day history of feeling generally unwell, fatigue, erythralgia, pruritus, finished 5-day course of antibiotics for urinary tract infection. Okay, now I remember this is antibiotic given for UTI infection, resulting in increase in the creatinine level, i.e. it's worsening renal function. And you can see now you're getting bloods and you're getting urine. So it's asking mainly about it's going to be asking about tubular interstitial nephritis because of the antibiotics, and in this case you would need a renal biopsy to diagnose. Yes, indeed, renal biopsy, and here it says tubular interstitial nephritis resulting into interstitial edema that can be seen by the biopsy, heavy infiltrate of the inflammatory cells and tubular necrosis. In the urine you can find some eosinophils as well, and the common cause will be hypersensitivity to antibiotics or NSAIDs, and the treatment will be to withdraw the offending drug and then managed conservatively, as we said, and the corticosteroids might be helpful. Okay, so that's that. Anything, and that's a good number of people answering this question. Not sure if there is anything else here, just showing a graph of the idiopathic PAN or polyarthritis nodosa, which is saying that in rare occasions or unusual presentation can result also to tubular interstitial nephritis. So this is polyarthritis nodosa, and I don't think there is anything else we need to think about in the explanations. Okay, so this was a good question. Let's go into the next question. Okay, this is a new question. Also, this is a question I've seen before. It's a lady with breast cancer. She was treated with surgery, chemotherapy, radiotherapy, and she was given the estrogen receptor um, antagonist because her cancer was positive for the estrogen receptor. So to help it, they gave tamoxifen, and then the patient started to have hot flushes, i.e., her postmenopausal symptoms has worsened. Here, the idea is to know that it has been worsened not because of the tamoxifen. Sorry, it worsened because of the tamoxifen, but the menopause has occurred already due to the chemotherapy. So it's a medical menopause. The estrogen antagonist did not result in the menopause but worsens the symptoms without flushes, and you treat that with progesterone. And in this case, you've got uh, few answers, possible answers, but here it is the migestrol, which is the progesterone. So you don't reassure here because it is debilitating, and so you need to treat it. Okay, so this is indeed the migestrol, and as I mentioned, the chemotherapy induced the menopause, and the hot flushes has been worsened with the tamoxifen or other anti-estrogen therapy. Because it's anti-estrogen, you need to give some hormones. It might be anti-intuitive to give progesterone instead of the estrogen, but that's the way it has been treated. So the progesterone effective in relieving the hot flushes. So you can give again the migestrol, the medroxyprogesterone, Provera, or you can give the northestrone. So here also is testing your ability to identify the trade names as well, not only the is it trade name or no migestrol? It's the scientific name. Okay, that's fine. Anything else we need to know? This is the reassurance to show that it is it's debilitating, and you can see here only 40% answer this question. Anything else? I'm looking for any graphs or things that would be nice to look at. But look, it's very long explanations. I don't recommend going through all these explanations. It's gonna take lots of time. Okay, so we've done that. So this question was about oncology. Question, did we answer? Yes, we did. What is the next question? This is a new question, so maybe this will be my last question in this series. This is a 43-year-old woman. She presents to the clinic very depressed, okay, about weight gain occurred over the past 2 to 3 years. Okay, this is, she has caring 3 young school-age children, takes no medication, no significant past medical history, blood pressure is slightly elevated, BMI is 31, so she is now obese because BMI above 30, fasting glucose is measured as 6.2. So now she is pre-diabetic, isn't it? So what is the most appropriate next step? Do you give metformin? I think it would help. I would choose this. Is it liraglutide? Is it gastric banding? Is it the group-based dietary intervention or prescribed exercise? So she's 43-year-old. You need to start with diet and exercise first about weight gain. Now she's very depressed. Would you give some group-based dietary intervention, or would you go directly to the metformin? So this is the question. Do you choose metformin, or do you go for sure you don't go for gastric banding yet, and the liraglutide is BMI 35. So I'm wondering whether, I'm not sure between either group-based dietary intervention, prescribed exercise, for a lady who's caring for 3 young school-age children. I'm not sure. So let's I am leaning toward the metformin, to be honest, because she's depressed. Let's see what is the answer. Oh, it is the group-based dietary intervention. As I mentioned, I was rotating between those two. Let's see their rationale. So the group-based weight loss programs shown to be superior to the individual effort, okay, with respect to the dieting. So Weight Watchers, Slimming World, and other clubs recommended to the patient for the initial weight management. Okay, so for initial weight management, you need to go for dietary and exercise. So why they didn't choose the exercise? Although prescribed exercise significantly impact cardiovascular fitness, little impact on the weight control. So mainly for weight control, go for that. Metformin causes modest weight loss. In this context, impaired fasting glucose, then diet and exercise superior to the pharmacological intervention. So here we knew that it is impaired, so it's not diabetes. If she was diabetic, then you would go for the metformin, and they say the diet is more effective. Okay, how many answered it properly? About 55%, and E 25%, which is the answered exercise. How many answered our question? Very little, about 10%. Okay, that's fine. So at least we understood this problem. Okay, here it's talking about anemia. Some of the graphs to show for anemia, some of the signs: cholinergia, iron deficiency anemia, erythropoiesis, vitamin B. Okay, so here just some explanation of other. What is this? Percutaneous endoscopy gastrostomy. Okay, if in case of intestinal or if a patient needs long-term feeding. Okay, that's fine. Okay, so I hope you benefited from these types of questions. I'm trying to keep these videos to 10 to 20 minutes so that you don't get bored. I hope you learned something. If you like it, please subscribe and hit the like button, and see you in the next lesson. Bye bye.